going to talk about worries, waistline, and weight in women, insights and implications of the hormone restoration model. Okay, I would say at least once a week I hear from a female patient, I weigh more now than I weighed when I was pregnant with my last child. And these patients are not pregnant. And this is just very damaging and daunting to a woman's self-esteem. And I had a patient say not too long ago, I don't understand it, Dr. Stevenson. My 17-year-old stepdaughter and I weigh the same. She looks like this and I look like this. What's happening to me? And there are body composition changes as women go through transitions and related to their hormone levels. And so let's look at a couple of phenotypes. This is what we call gynoid obesity, where there's increased weight distribution in the hip and thigh area. When I look at hormone levels in these patients, they tend to have high estrogen, low progesterone. And this may come on after pregnancy. It is also associated with uterine fibroids and breast cancer risk, this type of phenotype. The next is what we call an android obesity. These are the women that say to me, I've always been able to wear a belt. I've always been able to stuff in my shirt. I don't understand. My waistline is disappearing. It's the increased deposition of fat in the mid-body. And when we talk about body composition in women, if that waist circumference is 35 inches or greater, she has an increased risk of heart disease and stroke, as well as cancer and dementia. And this is a real easy little stress test you can do yourself at home. Pull your tape measure out of your toolbox or your sewing kit, and if your waistline is 35 inches, you want to do something about that. Get that below the 35-inch mark. When I test levels in women, I see higher testosterone and DHEA levels, normal or low estrogen levels, and low progesterone levels with this type of phenotype. We see this body composition change as women go through the perimenopausal transition and in their postmenopausal years. And we see an association with diseases such as metabolic syndrome, diabetes, hypertension, and hypertriglyceridemia, as well as the cardiovascular disease that I mentioned earlier. There's also a non-obese hyperandrogenism. I tend to see this in younger females, females with PCOS, with the female athlete triad, with eating disorders, with mood disorders. And they also, when I measure their hormone levels, have high testosterone, high DHEA, which are the androgens, and then normal or low estrogen and low progesterone. And so if you see the pattern here, what did all three phenotypes have in common? Low progesterone. I would say progesterone is my most common prescription when it comes to hormone supplementation in female patients. Worries in women will also impact their health. So maybe I'll see a patient and she's not so much concerned about her weight, but she has a lot of worries. She has a very high social burden. And what a woman is feeling and thinking impacts her health. It impacts her cardiovascular system. It impacts her stress response. And research studies have shown us that when women are depressed or anxious, they have elevated inflammatory and clotting factors. This is going to lead to that cardiovascular disease risk. They also have abnormal cortisol patterns, and I'm going to show you some cortisol patterns in the case histories a little bit later in this segment of the presentation. Women that have experienced childhood abuse or trauma have changes in the pathways that go from the brain to the adrenal glands to the blood vessels that lead to an increased risk of cardiovascular disease. Women with high hostility ratings also are at risk of cardiovascular disease. Now, when I say hostility or a hostile woman, you probably have an idea in your head as to what that might be. But in the psychological literature, the way that we define hostility or a high hostility rating is a woman who has a negative orientation towards the world. She perceives the actions of others to be exploitative or manipulative. She has difficulties establishing relationships of trust. Most of the time, her looming consciousness, that is the voice inside her head, that chatter in the head, or the monkey mind, which you'll hear about from the yoga ladies later, is feelings of guilt, resentment, frustration, anger that they can't express. I'm not good enough. They don't really mean that when they get a compliment. Just this type of negative think that goes on most of the time. When women are in that sort of state, they have an increased risk of cardiovascular disease because there are changes in the blood vessel related to release of hormones and inflammatory factors. And then finally, women with chronic unresolved psychological stress have accelerated aging, and they also have changes in inflammatory factors. I'll give you two examples of this. In the United States, we have 44 million unpaid caregivers. Those are 85% women that are taking care of a loved one, a family member who has a terminal or a chronic illness. And that means managing their doctor's visits and their medications, maybe helping with their personal hygiene and all their personal needs. And the caregivers are fulfilling this role on top of caring for their own families, raising their children, holding down a job, volunteering in the community, being involved in their church. So it's a very high social burden. And the research shows that within 6 weeks of assuming caregiver status, this is an added stress, that women have changes in immune function. Their natural killer cells drop, their T cell and B cell response is more sluggish, and they have elevated inflammatory factors. And I'm sure that you've all seen a situation where the caregiver's health becomes more seriously compromised than the patient that they're taking care of. And so when I am giving a diagnosis of dementia or cancer, I'm also talking to that caregiver about getting support, because their health will suffer as well as the patient's health through this process. Now, I'm not saying women shouldn't assume that role. It's a very fulfilling role for many women, but it's also very demanding emotionally and physically. Another situation of chronic unresolved psychological stress are women who mother special needs children. And they did a study a couple of years ago where the women were all age matched as far as their chronological age, but half of the women had special needs children and half of the women had normal children. And I'm very blessed to have normal children, which to me is quite tough, and I cannot imagine the challenges of taking care of special needs children. But when they looked at telomere length, which is a measure of aging at the cellular level, they found that the women of the special needs children were on average 5 to 17 years older than their chronological age. So there is definite wear and tear. And women in those situations, it's all the more important that they achieve hormone balance, that they engage in activities such as yoga and music and that mind-body-spirit connection to nurture their health. So sex steroids and steroid hormones are involved not just with the sexual response or bone density, which I know you hear a lot about the osteoporosis, but also with a sense of vitality, musculoskeletal pathways, not just hot flashes and mood, but also thinking, intellectual sharpness, crispness, cognition, the body composition that we've talked about. This is certainly not an exhaustive list, but any of my patients with any of these disorders, I want to know her hormone status. I want to get a hormone profile on her, because I may be able to minimize the manifestation of these chronic illnesses or decrease the number of exacerbations or flares of these illnesses, or maybe even decrease the number of prescription medicines that she's taking for management. If I test her hormone levels and, for instance, find that she's low in progesterone and start the progesterone supplementation, I find a response as it relates to these chronic disease states: migraine headaches, seizure disorders, fibromyalgia, chronic fatigue syndrome, asthma, skin disorders, arrhythmias, irregular heartbeats, irritable bowel syndrome, connective tissue diseases such as sarcoidosis, rheumatoid arthritis. And I'm going to show you some examples of these in case history. So if you have anything on these lists, you need a hormone profile. So these are some symptoms of hormone changes. We talked about bloating and headaches, mood. You can have irregular menses associated with hormone imbalances, changes with cholesterol and triglycerides, difficulty falling asleep or staying asleep or achieving a restful sleep, unexplained fatigue, tender breast, cognitive changes. I have patients tell me, I never have to write down numbers. Now I cannot remember numbers. I've never had trouble balancing my checkbook, and I can't seem to focus and balance my checkbook anymore. Difficulty with intellectual clarity and crispness and sharpness that they've noticed. Sugar cravings, food cravings, weight gain, decreased stamina. I've had marathon runners come in and say, I just can't run anymore. And I check their hormone levels, and they're in the gutter. And once we replace their levels to normal, then they are able to regain the stamina. I also do not like it when a doctor tells a woman, well, that's just part of being old, or you're just getting old, when the woman notices a change in her body, and the response is, well, that's just aging. Well, it's not just aging. If a woman had a lot of vitality and energy and stamina in her 20s and 30s, then she should have that in her 40s and 50s and 60s. It may decline just a little bit, but not profoundly. Cold intolerance, or these temperature changes, palpitations, constipation, unexplained aches and pains. So let's talk a little bit about how when women are stressed, it affects what they eat, and what they eat affects how they feel. So what sort of foods do women go for when they are stressed and need to be comforted? Well, in Texas, everything is a Coke. Whether it's a Pepsi or a Sprite, we call it a Coke. So the soda with the carbonation and the sugar and the caffeine kick. And then, of course, the chocolate, something sweet and high in fat, and then something salty and high in fat. Because our brains like salt and sugar and fat. When we gorge on something like that, it activates the pleasure center in the brain. And this goes back to the Stone Agers. When humans were in the Stone Age, they didn't encounter Bluebell ice cream and potato chips. They had to forage for their food, they had to hunt, they had to gather. But if they did run up on something salty or sugary or high in fat, they tended to gorge on that. The brain liked it. And so our saliva glands, our taste receptors in our brains are really hardwired to, when we encounter something like this, eat as much as we can, because we don't know when we're going to encounter it again. Now, 10,000 years later, we can easily have access to salt and sugar and fat. And so our challenge is how to minimize that and that influence. They looked at a couple of things as it related to gender and comfort food. And one of the interesting studies I found is that attitudes affect consumption and gender affects food preferences. So for the males, what sort of comfort foods do you think the males liked? They liked hot, hearty foods. So pizza, steak, potatoes, casseroles, hearty stews, that's what they went for when they wanted to be comforted. And they tended to go for the comfort foods when they were celebrating something. Okay, so winning a game, getting a promotion, something good happening is when the guys tended to go for the comfort foods. Now, for the females, what sort of foods do they prefer? Pastries, chips, ice cream, candy, things that you don't have to prepare, things that you can just pull out of the pantry or freezer and eat, right? Because who's making all that stuff for the guys? And if we're feeling bad and exhausted, just pull out the raw chocolate chip cookie dough. Don't even bother slicing it and putting it in the oven, right? So those were the types of foods that women tended to prefer. And when did women go for the comfort food? When they're feeling down, depressed, frustrated, anxious. That's when they tend to eat more of the foods. And like we talked about at the beginning of the talk, a lot of women spend a lot of time feeling guilty in that negative realm. Now, these are some of the comfort foods that my patients eat down in Texas. We have a book club called the Pulpwood Queens, and they get together once a month, and these are some of their recipes. This is called my Truly Scrumptious Chocolate Present. So you take a thawed pastry sheet, put that on a cookie sheet, you pile it with snack-sized Snickers, you gather up the edges like a bag and twist the top, brush it with butter, bake it in the oven until brown. And meanwhile, you're melting your Milky Ways in the microwave for the frosting, and then you serve this with vanilla bluebell ice cream. Now, these women really need progesterone, you know. Again, I actually made this recipe, and this is what it looks like. And everybody knows where Bluebell comes from, right? That's from Texas. Best ice cream in the world. And I could only eat one bite of this. But my husband and my 16-year-old daughter, they finished it off. Now, they're not just eating, they're also drinking. And these are the East Texas martinis. You take an assorted tropical popsicle box, assorted flavors of vodka. You choose your popsicle and your vodka. You unwrap the popsicle, put it in a pink plastic cup, pour in 2 shots of vodka over the popsicle, and dip and suck. And my patients tell me that the best combination is the mango popsicle with the orange Grey Goose vodka. And so this is how it looks. And I was able to finish this. But alcohol stimulates the GABA receptors in the brain. And the GABA receptors have a calming, sedating effect on mood. Well, guess what else goes to the GABA receptors in the brain? Progesterone. And what I do see in women as they go through the perimenopausal transition, they are drinking more. And they say, yeah, I used to have a glass of wine occasionally, now it's every night. Or I used to have a glass of wine with dinner. I can't calm down. I've got to have a couple of glasses. I saw a patient last week, she's drinking a bottle of wine a night because she just can't seem to calm down. They're exhausted, but yet they can't rest. You know, the brains are going, they're ruminating, they have a lot of anxiety. And so I do get histories from my patients are, have you found that you crave more alcohol or drink more alcohol? And then I find that their progesterone is low and they're able to get better control if we achieve hormone balance. So the sex hormones in women's health, they affect the brain, activity that has to do with mood, behavior, sexual responsiveness, appetite, and pain. They are involved in the body, in pain pathways and inflammation. And as it relates to the nervous system, the musculoskeletal system, the immune system, we have hormone receptors in the heart. The hormones are active as it relates to opening the blood vessels and protecting against rhythm disturbances and dysfunctions in the heart vessels. And then they're involved in metabolism, glucose-insulin interactions. This is where some of the sugar cravings come in. Let's ask you a little bit about your health worries here. So we're going to take a little poll, and I want you to be honest with yourself and honest with me. What is your greatest health worry? What is your greatest health fear as it relates to your personal health? How many of you would say it's dementia, getting dementia? Okay, so we've got quite a few hands on that one. How many would say cardiovascular disease? This would be heart attack and stroke. I would say more hands for that. All right, and then what about breast cancer? There's quite a few hands up with this one. And what about something else? Anybody, there's another disease that's their greatest health fear? Okay. So what are women more likely to suffer from these 3 choices? The leading cause of death and disability in North American women is cardiovascular disease. And so odds are that would be the one that you would suffer from and the one that you want to prevent. Of course, you want to prevent all of them, but your highest priority would be perhaps preventing the one that you're more likely to incur. So in the hormone restoration clinical model, The patient comes in with symptoms. She undergoes testing for an accurate assessment of her hormones. And then there's precise prescribing of individualized doses of bioidentical hormones along with nutritional lifestyle counseling, and then the hormone levels are monitored to remain in a physiologic range. And this model of care is available at the pharmacies that are sponsoring this event today. They have the hormone test kits, they have the hormone questionnaires, and I'm sure that you have a pharmacy in your community where they do offer the hormone consultations. Georgie McNeil is right here in Wolfville, and then there are also some in Bridgeton with Kirk, and you can find out more at the tables here about how to get your hormones tested. But I would encourage every woman in this room to know her personal hormone profile, and if her regimen, nutrition, lifestyle, diet, and hormones is appropriate for her and her needs. So here she's asking, has anyone seen my hormones? Where do we look for the hormones? Well, where I look is in the saliva. Now, I was certainly trained to do serum testing, but I was continually frustrated by serum testing because serum testing is not an accurate reflection of hormone levels unless that patient has a tumor that's secreting high levels of hormones. You're just not going to capture these subtle changes in the hormones that manifest as severe symptoms in midlife women with serum testing. And every day I see a patient who tells me, well, my doctor did blood tests and everything came back normal, so it's not my hormones. And I say, you haven't had your hormones tested appropriately or accurately. You've got to have the saliva test. The saliva test tells me what's going on in the tissue, and that's what I care about. I want to know what's happening in the brain, what's happening in the heart, what's happening in the breast, what's happening in the immune system. The hormones pass very transiently through the bloodstream, and so just finding out what's going on in the blood at one point in time is not helpful. Whereas gleaning this information from the saliva as the hormones pass through the salivary gland into the saliva, I see very good concordance between what the patient reports, what I suspect based on my history and physical exam, and the resulting hormone profile. And this is just comparing and contrasting the saliva to the serum or to FSH. If you've had an FSH test and your doctor has told you your hormones are normal based on an FSH, that's not an adequate evaluation nor appropriate evaluation. It's quite insufficient to categorize women as to where they are in the perimenopausal transition. So you need to have the saliva test. There are advantages with this model of care. We see a low incidence of side effects. You get individualized dosing, so it's not just choosing from 3 or 4 pills and handing it to a patient. I write a prescription that is specific for her and her needs. The compounding pharmacist can make up any possible combination. And the physiologic effects will mimic those of of hormones that are released from the ovaries. I've used the creams going through the skin. Transdermal is the preferred route of delivery. And speaking of that, that made me think of Robin McGraw. How many of y'all have heard about the hormones lately on the Oprah show, on Dr. Phil, on Robin McGraw? Great. I'm so excited about that information that's being shared. And I just loved Robin's testimony about how she went to the doctor and the doctor handed her all those prescriptions for the antidepressants and for the synthetic hormones, and how she said, no, I'm not taking this. I'm going to do my own research. I'm going to take control of my health, and I'm going to find out what's right for me. Okay, so we have the patient and the pharmacist and the physician or healthcare professional all communicating together with the hormone restoration model triad. And because progesterone is the most common prescription that I write, we did a study of progesterone only in postmenopausal women in 2004, looking at these clotting and inflammatory factors. Because again, there's a lot of misinformation, even in the medical community, about the natural hormones. The North American Menopause Society had come out and made the statement that we should conclude that the same risk as were demonstrated in the WHI with Provera would apply to progesterone. There's no evidence to support that statement, yet they made the claim. We refuted that with this study and published it in 2004 in Blood Journal. Do women just need progesterone? No. Some need DHEA, some need estrogen, some need testosterone. And so we followed that study with a 3-year clinical trial looking at compounded hormones in women ages 30 to 70. We have 150 women enrolled in this clinical trial. And women come from all over the state of Texas and even from other states to participate in this research study. Now, I don't have the other states on here because they wouldn't fit. Texas is too big. But this is where we are. We're east of Dallas, for those of you that are interested. And this is what we're finding with the transdermal plant-derived compounded hormones: a decrease in blood pressure, decrease in fibrocystic changes of the breast, decrease in blood sugar, decrease in depression, anxiety, decrease in pain, decrease in triglyceride levels, decrease in inflammation and clotting factors, and a decrease in hormone-related symptoms. We published our initial analysis in 2007 in Circulation, a journal of the American Heart Association. We have another publication in ATVB in 2008. And, so when your doctor tells you there's no studies about this, the answer is yes, there are. And the pharmacies have copies of my papers. They make them available to the physicians in this area. And in 2008, November, we published this paper, Compounded Transdermal Hormone Therapy Effects on Hemostatic Immunologic Factors Peri- and Postmenopausal Women. The acceptance rate for these papers is about 13%. And there are tens of thousands of papers that are submitted. So I just want you to have an idea about the quality of the research that we're doing. And we were not only encouraged in that our paper was accepted, but we were one of 32 papers from over 4,000 selected for a news release. It's a tremendous honor. And I did interviews with WebMD, Medscape, Family Practice News, Cardiology News, OB-GYN News, UK Reader's Digest. You can go to my website. I think, did everybody get the bookmarks? I brought some bookmarks that have my website. They're on the book table. And you can see printouts of these, or you can get them from the pharmacies.